Good morning. You are being hosted at a great Medicaid Medicare dual special needs planning webinar with the Lucys. Lucy Cantrell from the ARC of Virginia and Lucy Beednell from the ARC of Northern Virginia. This is an area where we get so many questions each year, and it can be complicated and overwhelming. So we're incredibly grateful for the team at Virginia Medicaid who stepped in today to give us some really good answers and help families navigate this process that we know looks often a little bit different if you're coming through the door of perhaps your child has a waiver and they're getting Medicare, younger in life relative to a parent retiring, all those kinds of things. So we'll work through that today, and we're excited to have your questions. If you're watching this recorded later, always feel free to go to the arcofnova.org. In the upper right hand of the screen, there's an orange and yellow rectangle that says help. If you put a question in there, it comes directly to me. You can reach out anytime if you need follow-on questions, a copy of the slides, etc., anything like that. So without further ado, Matthew and Rhonda, we'll let you take things away today.
Okay. Thank you very much, Lucy. My name is Matthew Behrens. I am the Senior Policy Advisor for Complex Care and Duals Integration at DMAS. Mostly what that means, I work on kind of both the Medicaid managed care side, doing contracts, waivers, that sort of stuff, but then also work with the DSNP program as well. And look forward to speaking with you today. I know Rhonda is on, but I also want to make a note. We have another team member who's, I think, having trouble connecting her audio. Natalie Benke, and so you may see her pop up as well. But Rhonda, can you go ahead and introduce yourself?
Hi, good morning, everyone. I'm Rhonda Thyssen. I'm a senior policy analyst with the Integrated Care Division at DMAS, and I am on Matt's team. And as Matt mentioned, we work on issues relating to the needs of our members that are dually eligible, like we're going to discuss today, and also contracts and other services for people with complex care needs.
And then I think I'm going to share my screen. Hold on. It says sharing is not requested, so I'm going to send a request.
Give you special permission.
Okay. Just let me know when you all can see my screen.
Not yet, but it looks like you do have permissions.
Yeah. Okay. All right. How about now?
It's here.
Okay. Excellent.
Great.
All right. And I'll put it into presentation mode. Okay. All right. So again, Matthew Behrens, work at DMAS. Today we're going to talk about duals, like dual eligible enrollees, Medicare, Medicaid integration, and then at the end, we're going to talk specifically about dual eligible special needs plans, what they are. Then we also have a policy change coming up for January 1, 2025. So we wanted to talk with that as well. Beneficial policy change, but it is sort of a little bit complicated once we're trying to highlight that for members and some of our provider community. First, we're just going to start with some information. Some of you may know this, some of you may not. We always try to level set when we do these presentations because duals and kind of Medicare, Medicaid integration can be a very complicated space. So I try to give some kind of high level information. And at first thing is who is a dual eligible enrollee? So simply a dual eligible enrollee is someone who is eligible for both Medicare and Medicaid. So Medicare eligibility, it's a federal health insurance program. You have to be age 65 and over, or under 65 with the disability, or have end-stage renal disease. Majority of people are going to be the 65 and older and under 65 with a disability. And then, of course, Medicaid is the state health insurance program, and that kind of eligibility for the Medicaid program is really based off of income. And it will kind of vary by population, it will vary by state, but it is sort of an income test resource eligibility. So,
Matt, I'm sorry to interrupt, but
no.
What I'm seeing is the non-presentation mode of the first slide.
Okay. No, thank you for saying that. So are you seeing just the slide deck, Rhonda, or?
Yeah, the edit mode of the slide deck.
Okay,
Yeah.
so you see like the thing on the side. I
Yeah.
wonder why that is. Because that's not what I'm seeing.
Well, my famous troubleshooting is to stop share and start reshare.
And you might need to turn off
Groundbreaking advice.
presenter mode. You may need to turn
There
off.
we
There
go.
you go. Now okay. Yeah, so turn off presenter mode and then you should have one full.
Can you see it now or no? Or is it
This
still
is
the?
great. Now we've got the green diamond in the middle.
Okay.
Yeah, we're seeing your presenter mode. So if you go up to display settings, you should be able to eliminate that.
I cannot eliminate that.
Okay. Well, okay.
Yeah. Okay.
Complicated.
Yeah. But you are on the slide, the first slide with the little green
Yes.
diamond in the middle. Okay.
Yeah.
At least we have that. So, all right. I'm sorry, you all just we're used to using Teams. So sorry for switching between different platforms can still catch me out. All right. So so dual eligible enrollees. There are kind of generally two types of dual eligible enrollees. There are those that we would call full benefit duals and then partial benefit duals. For the most part today, what we're going to talk about is going to be impacting the full benefit duals. But we'll spend some time talking about partial benefit duals as well. So just kind of high level what they mean. Full benefit duals are simply folks who are eligible for both kind of full Medicare and full Medicaid benefits. These folks will also get Medicaid covered cost sharing of Medicare expenses, so like paying of premiums, deductibles, and co-insurance. Partial benefit duals are folks who are eligible for full Medicare. They don't meet the Medicaid income levels, but their income is just low enough where we'll cover kind of their Medicaid will cover their Medicare cost sharing again. So again, paying the premiums, copays, and deductibles. All right. And then so then we have kind of 70% of duals have chronic health conditions. So we'll see a lot of folks with like heart disease and diabetes or behavioral health and a physical disability. So really kind of highly kind of complex healthcare needs. Generally, they account for 20% of Medicare enrollment and 34% of the Medicare spend. And on the Medicaid side, they account for 15% of Medicaid enrollment and 32% of the spend. Not that we're necessarily too, concerned about the dollars. It's really more so kind of just a sort of illustrative of how needy these individuals can be, kind of help from a healthcare perspective. Across the country, there are 66.5 million Medicare enrollees in the United States. And there are, of those, about 34 million, about 51% are in original Medicare, that's Medicare fee-for-service, and about 48% are Medicare Advantage plans. In 10 years ago, kind of from this data in 2013, 28% of all Medicare enrollees were enrolled in the Medicare Advantage plan. And so now you can see like in that 10 years how it's grown, so now we're at 48%. So it's a huge growth in Medicare Advantage plan enrollment. And we will kind of talk about Medicare enrollment options, like what is original Medicare and what is the Medicare Advantage plan coming up next. There are, so of the 6.5 million dual eligible enrollees, 12.8 million, I'm sorry, 66.5 Medicare enrollees, 12.8 million of those are dual eligible enrollees, 9.4 million full benefit duals, and 3.4 million partial benefit duals. Now in Virginia, kind of specific here, and this is 2023 data, there were 238,000 duals. You'll notice the asterisk there. 2023, we were still kind of, I don't want to say unwinding from the public health emergency related to COVID. So these numbers are actually kind of inflated. During the COVID public health emergency, we were not doing reassessments of individual eligibility. And so our Medicare enrollment roster grew. And so we ended up with a kind of higher number of enrollees over that period of time. So generally, and we're getting back to it now, is like any given month, we're going to have around 120,000 full benefit duals. Partial benefit duals numbers really stays about the same. We're going to be somewhere between 30,000 and 40,000 partial benefit duals any given month. All right, so Medicare enrollment options. And again, probably stuff that a lot of you know and understand. But if not, so on the Medicare side, you have a few different choices, right? You can have original Medicare with a Part D plan. This is also called traditional Medicare, Medicare fee for service. It covers your parts A and B benefits. We'll talk about what Part A and Part B is in a little while. But also your Part D will come through a different organization. We also have kind of individuals that can also purchase a Medigap plan that will help with Medicaid cost sharing. We'll talk about kind of Medigap plans in just a second. But the other kind of main enrollment option would be a Medicare Advantage plan. A Medicare Advantage plan is just an HMO or managed care organization that is providing Medicare benefits. Most Medicare Advantage plans have to cover parts A, B, and D. Every once in a while, you'll find a Medicare Advantage plan that doesn't cover Part D. That's very rare. Only very few of those exist. And I'm actually not actually aware of any that exist in Virginia, but there certainly could be some that are out there. Most Medicare Advantage plans also will have to offer enhanced benefits. And these are sort of kind of add-on benefits. So if you think about kind of what Medicare covers, enhanced benefits would be things like, hey, we'll give you some dental, or we'll give you kind of money towards hearing or vision or something like that. Those would be enhanced benefits. And then again, a Medigap, kind of supplemental coverage. So I will say if you're dual eligible, what I have heard CMS say is that if you're a dual eligible enrollee, you really don't need a Medigap plan. However, I'm not going to tell you if you're someone out there who has a Medigap plan that you can disenroll from it. But the Medigap plan kind of is supposed to kind of provide wraparound services and cover the Medicare cost sharing. That's what, if you're a dual, as we kind of talked about in the previous slides, Medicaid does that for you. So you may not need a Medigap plan, but it is, Medicare enrollees can purchase a Medigap plan. Just wanted to highlight there. On the Medicaid side, your enrollment options are different. With very few exceptions in Virginia, almost all Medicaid enrollees must be enrolled in Medicaid managed care. Medicaid managed care will cover kind of all of your acute primary behavioral health, long-term service supports, and some waiver services. I want to say kind of just that kind of some waiver services, and I want to make the distinction here. CCC Plus waiver enrollees will have all their services, including their waiver services, covered through their Medicaid managed care health plan. Or if you're a DD waiver enrollee, you'd have your kind of acute and primary services covered through the health plan, but your waiver services are going to be covered through fee for service. So hopefully the kind of distinction makes a little sense, but there really is, for the Medicaid side, unlike Medicare, where you can be in fee for service or a Medicare Advantage plan. For Medicaid, it is really it's a state mandate that everyone be in managed care. All right. So this, I wanted to kind of talk about the differences in coverage and kind of how Medicare and Medicaid sort of interact, and what we might cover in terms of services. So on the Medicare side, you get your Part A, which is generally considered your hospital. So that's going to be like inpatient hospital care, skilled nursing care, hospice, and home health. Part B is generally just called your medical coverage, and that's going to be physician services, outpatient services, DME. There'd be other things under Part B as well, but this kind of big buckets. And then you're going to have your Part D, your prescription drugs. On the Medicaid side, now in a world where you're not a dual, you're just getting Medicaid, Medicaid would cover all the things that Medicare does. And we would cover the things that are here on this slide, like the long-term services and support. So that's going to be like custodial stay in a nursing facility, which custodial stay, that means like if you're residing in a nursing facility, that's custodial coverage. Medicaid would cover that, where Medicare wouldn't cover that. Also, long-term service supports kind of under that umbrella would include both the CCC Plus waiver and the DD waiver. We also cover what we'll call community behavioral health services. Now, Medicare does cover behavioral health services, but their general coverage of behavioral health is going to be sort of kind of traditional behavioral health services like talk therapy, seeing a psychiatrist, seeing a psychologist, that sort of thing. For community-based health services, we'd think of things like crisis intervention, psychosocial rehab, and then particularly with like the substance use disorder services, we have a program called ARTS for a lot of kind of community-based services like targeted case management, that sort of thing. Those would be services that aren't covered by Medicare. Medicaid, we also covered dental for everyone. That was a change actually a few years ago. It used to just be kids, but now we cover dental for all individuals. And then, of course, as we've talked about, we do the Medicare cost sharing as well. So then how do these two kind of things interact, right? Because there's a lot of overlap, but also there's some differences in what gets covered. So your Medicare is always your primary insurer, and your Medicaid is always going to be your secondary insurer. In fact, when you're a dual, CMS will often say the kind of the Medicaid services are just kind of wraparound services. I don't like that because I think if you're a waiver enrollee, you kind of don't think of like your waiver services as wraparound services, right? Like they're really important to you. And maybe even more important than something like your physician or somebody. So I don't like to think about wraparound services, but there is sort of a distinction that Medicare, like if you're going to go see a physician, even though Medicaid would cover physician services, if you're a dual, that's going to be covered through your Medicare first. And Medicaid would pay the cost sharing. If you are a waiver recipient or long-term service support recipient, those services would be covered by Medicaid. So essentially, when you're enrolled in these two programs, you get kind of both of them. They sort of overlap or wrap around, if you want to use that term. But the Medicaid is generally your secondary insurer, unless it is a Medicaid-only covered service. I do also want to point out the little kind of red font at the bottom of the page. This is the first one we're going to come across for these, but we've sort of layered these throughout the presentation. Find out what Medicare covers. That's actually a link. So when we'll send out a slide deck after this, you all can kind of have that and link to the CMS webpage. We're going to go on and kind of talk about the parts of Medicare. I'm going to go through these pretty quickly because we just sort of talked about them. But I do want to point out again, the red font here for Part A and Part B. Those are also links. So those will take you, I believe, to a CMS webpage. I think that's where we're linked to there. That will kind of cover to discuss what does Part A cover and then what does Part B cover. Right. Part C, we've talked about Medicare Advantage plans, but we haven't kind of talked about those Part C plans. So if you noticed before, kind of on not the two slides, there's Part A and then there's Part B, and then we kind of skipped Part C and went right to Part D. So what is Part C? Part C is just Medicare Advantage. Again, it's not necessarily like a different suite of services. Like Part A is sort of a different suite of services than Part B. You're going to cover different kind of modalities of care. Part C is really going to be this is how you're getting your Medicare benefits. So I just want to kind of highlight that sometimes you're going to hear people talk about Part C or like a Part C plan. That's just Medicare Advantage. Again, I want to kind of, again highlight the extra benefits. Again, just point out that you do get that. And this is sort of when making enrollment decisions, a lot of people ask, well, what's the benefit of being in a Medicare Advantage plan versus a kind of Medicare fee-for-service? The benefit of Medicare fee-for-service, you can go to any doctor that takes Medicare, which is a lot, right? There's a lot of doctors out there who take Medicare. Medicare Advantage, you're generally limited to only doctors that are in network for that health plan. However, the trade-off is going to be you're going to get these extra benefits. So vision, hearing, dental, health and wellness programs. Sometimes it's going to be extra cost sharing. So, when we talk about Medicaid cost sharing, we don't cover, the Medicaid side doesn't cover Part D prescription copays. But you'll find some Medicare Advantage plans will buy down kind of or cover some of your copays for the prescription drugs. Also a lot of things that kind of become more popular now, like you get housing allowances or payments toward utilities, gym memberships, food and kind of delivery services and stuff like that. So like you really kind of, there is a lot to be said about the enhanced benefits, but the real kind of trade-off and where people generally end up making decisions between Medicare fee-for-service or Medicare Advantage is, do I want my choice of any provider, or do I want these enhanced benefits? That's generally where people are going to be making that distinction. Part D, again, I'm not going to talk a ton about this again, because I think hopefully you all can understand Part D is coverage of prescription drugs. So this is if you go to the pharmacy to get something, this is where it's going to be paid through. But I do want to highlight that last bullet there. And again, you'll see a link in there about the Medicare Low Income Subsidy Program. So this is a program that you would actually have to apply for. At least currently you have to apply for it. So persons who are low income beneficiaries, including everybody who qualifies as a dual eligible enrollee in the state of Virginia. So if you're a dual eligible enrollee or the person you're working with is a dual eligible enrollee, you qualify for extra help. However, you don't just get it, you have to apply for it. You actually apply for it through the federal Social Security Administration. What this does is that this, you say like, I have low income, they will reduce your Part D copays, kind of based off your income. So it's kind of tiered. So the lower income, the less you pay, the more that Social Security Administration will cover. The higher income, your share will be a little bit higher. And then of course there's a cutoff point where you just don't qualify anymore. We want to really highlight this because in Virginia, we have a really low uptake rate, meaning we have a lot of dual eligible enrollees who aren't in the low income subsidy program. So we always try to educate people, go out, apply for this. This link will take you to kind of some more information about the Medicare low income subsidy program, but there's also, you have to find a way there to like apply or just kind of link to Social Security Administration. It does take a while to get going. I think I've heard up to like 6 months for like once you apply to Social Security Administration, but it is definitely worth it. Really can help reduce Part D costs by a significant margin. I will say there is a rule change coming in this. So starting, I don't remember exactly what year, but starting, I think in 2026, or it might be kind of late 2025, you will kind of, once you kind of apply for Medicaid and get into Medicaid, you will automatically be applying for the low income subsidy program. But for right now, you have to apply separately. Earlier, I had mentioned that we were going to talk about kind of partial duals a little bit. I do want to highlight this. We get quite a few questions about the cost sharing and qualifying as a partial benefit dual. Like, what exactly does that mean? So I want to try to highlight that today and just get in discussion. I'm not going to spend a ton of time here, but happy to come back and answer questions if you have them. And I don't know how kind of a caregiver or a member would experience this, but generally kind of the cost sharing kind of as a partial benefit tool is generally called Medicare savings programs. So this is the thing that we talk about where it is Medicaid covering the kind of the premiums, co-pays, co-insurance of the Medicare cost. So generally, if you are a dual eligible enrollee, you are eligible for this. If you've actually already been enrolled in it, so it's not something you have to go and enroll in separately. But if you're kind of applying for Medicaid and your income is too high for kind of full Medicaid, you may qualify for a Medicare savings program as a partial benefit dual, but you'll be automatically enrolled in that unless you want to opt out because it is voluntarily. You don't have to take it. Then again, so is Medicaid. But for the most part, like when you're applying for Medicaid, you'll just kind of generally be put into one of these categories. We'll use some terminology here. They're kind of four program coverage levels, and they're all based off of your income. So you kind of think about them as tiers like QMB is lowest income, QDWI be like highest income. And a lot of acronyms here. I don't want to get too bogged down in acronyms, but it is kind of how CMS and DMAS do sort of understand kind of putting people into sort of the kind of buckets based off of their income. So the first one would be QMB. These are qualified Medicare beneficiaries, and there's also QMB plus. The QMB plus individuals are going to be full benefit duals. QMB, or sometimes they're called QMB only, are going to be partial benefit duals. And then specified low income Medicare beneficiaries, and I will make a note here, in Virginia, we call them special low income Medicare beneficiaries because Virginia, we always have to do something a little bit unique. So those are kind of Slim Bs. There's also Slim B plus. Slim B plus is also full benefit dual eligible, whereas Slim B is a partial benefit dual eligible. And there's qualified individuals and then qualified disabled and working individuals. So again, just kind of think about it sort of tiers. QMB's lowest income, Slim B is a little bit higher income, QI, QDWI a little bit higher again. Again, there are more notes in here, and I'm not going to go through all of this, but we do provide this for you to kind of help you go through and understand, like, well, what are the income levels? And so we have provided those in this slide deck. So you can kind of see those, understand it, and hopefully it all makes sense. But again, if not, you can always follow up and ask us questions. I do want to point out something with the Slim B plus. So the Slim B plus, these are full benefit dual eligible enrollees. So they have a higher income limit, but they meet kind of full Medicaid eligibility through what's called a medically needy aid category or a spend down category. So for the most part, these are going to be people who are like residing in a nursing facility. And their income is just high enough where they're not going to qualify for Medicaid just based off their income alone. However, because they're in a nursing facility, and the nursing facility costs money, as soon as the nursing facility has them pay their share, they're going to become Medicaid eligible at that point in time. And so this would be sort of like monthly, right? This person become Medicaid eligible and then not Medicaid eligible, and Medicaid eligible and not Medicaid eligible. But these individuals, we just call them kind of spend down rules or kind of medically needy grouping. And we just say, you're just eligible. So we're not going to have you kind of going on and off eligibility. There are also folks who are in the community that are in this situation. And this is where it can get really tricky because there are different kind of spend down rules depending on I think your income level and also like, are you in a waiver? Are you not in a waiver? So we can talk about those more if anyone has questions about spend down. It's a very complicated area, so I didn't want to get into it if we didn't have anyone focus who wanted to focus on it. But again, happy to answer questions about that. And again, QI and QDWI, they can kind of just higher income levels. But do note, like, higher income levels, we may only pay your Part A premiums. We may not pay your co-pays and co-insurance, but like for like QMB, we're going to pay your premiums, deductibles, and co-insurance. So that will be a little bit of a difference as well as we go through that. All right. Now kind of moving on to a different part of our presentation. So this is where we're going to talk about special needs plans. So earlier in the presentation, we talked about your Medicare enrollment options. It's Medicare fee-for-service and then Medicare Advantage plans. So Medicare Advantage plans were started back in the 1970s. And pretty quickly after that, the plans themselves, member advocates, provider advocate groups started recognizing that the Medicare Advantage plans just really weren't built to kind of handle individuals that had special needs. And so it took a while, but back, I think it was, I'm probably going to get these dates wrong, so don't hold me to this, but it was back in the 90s, they started pilots to say, let's start trying to enroll some of these individuals in kind of what Congress called special needs plans. And then eventually in the 2000s, they formally got created as these three types of special needs plans. There are institutional special needs plans, chronic condition special needs plans, and dual eligible special needs plans. Do note, special needs plans are a type of Medicare Advantage plan, but not all Medicare Advantage plans are special needs plans. So that's sort of the distinction, is that a special needs plan is sort of a subgrouping of a Medicare Advantage plan. We're mostly going to focus on DSNPs today. That's what we're going to spend the next bit talking about. But I do want to kind of shout out I-SNPs and C-SNPs. I-SNPs are only for persons who are residing in an institution or those who meet institutional level of care but reside in the community. there are about 93,000 members in an I-SNP in the country, so pretty small enrollment total. But they are kind of they're sort of kind of gone up and down. This is sort of on an increasing popularity. Most I-SNPs are offered by like a nursing facility association. So it could be like a group of nursing facilities comes together, forms an association, creates a health plan, and then creates an I-SNP. So when members enroll, come into their nurse facility, they can be enrolled in an I-SNP at that point. Then there's chronic condition SNPs. Again, pretty small. There's only about 40,000 of those in the country, or people enrolled in the C-SNP in the country. Sorry, you can see that. Mostly they just kind of focus around like a single or maybe multiple disabled chronic conditions. So a lot of these became very popular with the AIDS epidemic, and we're kind of focused in sort of communities. I think the single largest C-SNP still exists in New York, where it's mostly like Hispanic enrollees in who are still kind of experiencing HIV and AIDS at a higher rate than other folks in the country. And then the one we're going to talk about the most today is the D-SNP. D-SNPs, as it sounds, dual eligible special needs plan. They can only enroll individuals who are dually eligible. So again, what we're talking about today in both Medicare and Medicaid. They must provide care coordination. They must offer parts A, B, and D and enhanced benefits. And the part that I think is going to be important here, they must contract with the state. Because of that language, right? Like the state gets to kind of decide what the D-SNP is going to look like. And so part of the point of a D-SNP is to try to create bridges across the Medicare and the Medicaid, right? Like Medicare and Medicaid, two monolithic systems, not easy to navigate on their own, and they were never intended to work together. And so the D-SNP, really kind of the point of the D-SNP is to sort of build bridges across the Medicare and Medicaid to make it easier for members to navigate, and hopefully as well as providers. So that's the point of it. States can kind of decide how robust those bridges are going to be. So how integrated, how coordinated the Medicare and Medicaid are going to be. So again, this is kind of mostly covering what we just talked about, but I did want to also kind of point out that duals are protected from cost sharing. So again, we've talked about this kind of the Medicaid cost sharing. I just want to note, like, this member kind of advocacy. If you are a member or a loved one is a member who's a dual eligible enrollee, you should not be getting billed by your provider. The provider, what they should be doing is they bill Medicare for, let's say it's like a physician services, they bill Medicare, the Medicare will pay their portion, and Medicare will tell the provider, go bill Medicaid for the remainder, and Medicaid will pay our share of the remainder. Now, that doesn't mean we're going to pay the full cost, right? So we have some rules on how we pay in Virginia. I'm not going to get too far into the weeds on this, but a lot of times what we'll mean is like, let's say like the bill is $100, Medicare pays $80. The provider could bill us for that balance of $20. However, if like our maximum reimbursable limit for that service is $90, actually what we're going to pay the provider is $10. Hopefully that makes sense. Like we don't kind of cover the full cost of it all the time. We cover kind of what we would consider like the Medicaid portion of it, or what up to our full limit. But just know, you as a member or your loved one, the person you're the caregiver for, should not be getting billed for those services. Now, there are kind of always exceptions. What if you're going and seeing someone out of network? What if you're going and seeing someone in a different state? There can be kind of some different rule. Or what if you're getting a service that isn't covered by Medicaid? Then you might actually have something where you may actually have to pay. But your provider should be letting you know that beforehand. We're just going to try to make sure that you all understand that. It's another good point of education we always try to point out when doing these presentations. All right, so kind of D-SNPs in Virginia, we'll talk about the current landscape. And again, as I noted before, we have a change coming up. And so this will lead us into that change. So in Virginia, generally, we've really had a focus on a high level of integration across our DSNPs and our Medicaid managed care plans. So we've done a number of things to do that over the years. First off, we started our DSNP program in 2017, so they haven't been around for very long. I think way back in the beginning of this presentation, we talked about Medicare Advantage and enrollment, and we talked about how it's grown so much across the nation. Well, Virginia's actually had even a higher rate of increase. When I first started doing this in 2017, Medicare Advantage enrollment in Virginia was at like 12%. Now we're at like 42%. So in a short period of time, there's been an explosion in folks who are enrolling in Medicare Advantage plans. That goes the same for DSNPs as well, because we didn't actually have them until 2017, but now we have a high number or a good number of people enrolling in our DSNPs. And we have really tried to focus on, like I said, integration. And so our first step was that we have 5 health plans that we are contracted with for Medicaid, and we require all those health plans to offer a dual eligible special needs plans. We do not allow other entities to come into Virginia and offer a DSNP program. They could, like we could have a contract with some other health insurer that wants to come in and just provide a DSNP, but we don't do that because doing that then limits our ability to coordinate and integrate across the Medicare and the Medicaid. So when we started this in 2017, we said all of our Medicaid MCOs are going to have a DSNP, and all of our DSNPs have to be Medicaid MCOs. So in Virginia, these are our 5 managed care entities. Now, I will put an asterisk there. You may have heard, you may not have heard, we are in the middle of reprocuring our Medicaid program. It is currently under kind of say court order. It's a sort of lawsuit. The procurement has been held up because one of our plans, we went to bid to award from the bidding, and one of the parties who didn't get awarded a contract has filed a suit saying we didn't actually kind of follow the rules properly. And so right now we're kind of in this limbo state. But as of today, right now, these are our 5 Medicaid health plans, and these are also our 5 DSNP programs. I should say DSNP providers, not programs. Historically, we've allowed people to kind of be what we'll call, say, unaligned. And so you can choose one plan for your Medicaid coverage and a different health plan for your DSNP coverage. So you could be in Aetna for your Medicaid and Anthem for your Medicare. Reason people have done this is, again, a lot of times is they enhance benefits. It is, well, I get a gym membership from Aetna and I get utility benefits from my DSNP Anthem. And so now I get these 2 great kind of sets of enhanced benefits that I can use. And so that's a lot of times why people will be unaligned. However, when you are unaligned, it's harder for us to coordinate care across the Medicare and the Medicaid. We have care coordinators for both DSNP and for your Medicaid side. And so those care coordinators have to both all go out and do health risk assessments and plans of care. But you're going to get one from your Medicare plan, and then you're going to get one from your Medicaid plan, and they don't necessarily talk. We try to get them to sort of share data across different platforms. That was sort of our first shot at, like, can we allow individuals to have this, different sets of enhanced benefits, but still get kind of integrated care? And eventually what we kind of quickly found out was that it just doesn't work. There just wasn't a good enough platform across the Medicare and Medicaid to communicate, share health records, share health risk assessments, coordinate on, how do we help somebody when we know that they have a specific need? And so that's really been a problem for a lot of our dual enrollees who are unaligned. We've also seen when people are unaligned, we also have a lot of challenges with billing, service authorizations, claim processing, and then a lot of confusion for members around grievance and appeal procedures with different companies, right? So if you go and you're trying to get a service, but you're getting denied, well, you're dual. Are you getting denied by the Medicare side? Can the Medicaid side cover it? How do you, who do you appeal to at that point? And so it becomes kind of difficult to do that. And so that leads us to the change that's coming for January 1, 2025. And that is that starting January 1, 2025, we're going to move to what's called exclusively aligned enrollment. Exclusively aligned enrollment is an arrangement where if you are choosing to enroll in a DSNP, and it is voluntary, you do not have to choose to enroll in a Medicare Advantage plan, and you don't have to choose to enroll in a DSNP. But if you choose to enroll in a DSNP, you will be required to enroll in the Medicaid managed care plan by the same company, right? So if I'm enrolling in Aetna for my DSNP, I will be in Aetna for my Medicaid. The member doesn't actually have to do anything. We will do it on kind of through our system. So we will be able to see, oh, Matt's enrolled with Aetna for a DSNP. DMAS will assign that person to Aetna for their Medicaid, but that relationship cannot be broken. So a member can no longer go in and be unaligned. This will help us with quite a few things. Just kind of an illustration of what we just talked about. So you can kind of see the graph on the right-hand side of what is aligned and then what would be not aligned. Benefits of exclusive line enrollment. So why are we doing this? First off, I would say in part reason that we're doing this is because it's actually a rule now. It's a combination of both state rule and a federal rule that are requiring us to make this move. However, this is a move we've been actually looking at for several years, and we actually wanted to do this back in 2020 and 2021, but we got held up. There were other roadblocks in place, kind of other things that were priorities for administrations and different RFPs and kind of system changes, stuff that were just kind of blocked us from being able to do it. So now we are finally being able to do this. So we do at DMAS think that this would be very beneficial for those people who want to enroll in a DSNP. The benefit is all your services and benefits are managed by the same parent organization. You're going to have coordinated delivery. You will have integrated member materials, so like one ID card, one summary of benefits, one list of covered drugs, one pharmacy directory, right? And it's going to cover all of your Medicare and all of your Medicaid kind of in one spot. You're also going to have one care coordinator. So no more of those two care coordinators. One's trying to get you to do something and the other one's trying to get you to do something else. You'll have one care coordinator that will be responsible for coordinating both your Medicare and your Medicaid, or at least helping you coordinate both your Medicare and your Medicaid. There's also going to be kind of a single appeals and grievance process, but there's also going to be kind of a single sort of service authorization request process. So imagine yourself going in and looking to get a service from a provider and it requires a service authorization. The provider would send that to your health plan. Let's just say I'm going to say Aetna in this case. So they send it to Aetna. Aetna would first look at it through the lens of Medicare. Right? Does Medicare cover this service? If they approve it, then you're done. But if they deny it in part or in full, what they would then do is say, all right, well, actually, I'm going to go and check and see, can this service be covered by Medicaid as well? So you can have things. And so this is kind of one of my favorite examples because I recently learned this and it sort of blew me away. DME for Medicare. Some people will have chair lifts in their home. Medicare actually only covers the motor. So they'll pay for the motor, but they're not going to pay for the chair. They're not going to pay for the install. They're not going to pay for the railing that kind of goes up the stairs, but Medicaid would. And so how this would work in this instance, like person goes in, Medicare will say, yep, we're going to cover the motor. And then the rest of would get kind of denied on the Medicare side, but then passed over to the Medicaid side. And the Medicaid would say, oh, we cover the chair and the install and all that. And so the whole service would be covered, right? You wouldn't have to say, well, I'm going to go to Medicare and get the motor covered, and then the rest of it gets denied. But then you say, go see Medicaid, and then you should go bill Medicaid, and then Medicaid do it. It's just kind of one process. And again, if anything gets denied, you have one appeal process as well. So it is, we do see that as kind of being beneficial. For any of you who have been around long enough to remember the Commonwealth Coordinated Care Program, which is actually, I started working here at DMAS with the Commonwealth Coordinated Care Program. That was actually a program that really kind of formally integrated Medicare and Medicaid into one plan. This is going to feel very similar from a member's perspective. It's not the exact same thing. We don't kind of have a lot of the back office sort of coordination It's not that, but from a member's perspective, it's going to feel very similar. So it should be simpler to navigate, simpler to kind of access services. Of course, I don't want to oversell it. This isn't going to be, a cure-all to all that makes managed care difficult. But we do hope we're going to see a lot of benefits out of it. We do know across the nation, people in kind of integrated plans and even those who were back in the CCC days, everybody member experience kind of from surveys, everyone was much happier. So we see significant improvements in member satisfaction. We also see some improvements in health outcomes. But I don't want to oversell that because that data can be skewed by by what someone chose. Right. So like maybe a healthier person chose to be in an enrolled in a DSNP, where someone who was sick was didn't want to make a change because they just didn't want to risk it at that point in time. And so they didn't enter. So that data can be a little bit weird, but we certainly know people are more satisfied. They find it easier to access services and access their benefits. So what would be the possible impact to members? So possibly if you are unaligned, you will be changing your Medicaid health plan. This will happen on January 1. So really you'll be assigned on December 18th and you will be changed to on January 1 will be effective date. This will also mean a possible change to your Medicaid providers. And this is really important for kind of members and caregivers to understand, is that if you are getting waiver services, particularly CCC plus waiver service, right? DD waiver services is covered through fee for service, so this doesn't really apply. But for if you're getting LTSS services, or if you're getting CCC plus waiver services, not every health plan is going to have the same group of providers, right? And so maybe you're going to move from Aetna to Anthem. Anthem may not have your providers in their network. And so you may need to kind of look at you may have to either switch providers, or you may want to be making a different choice for your Medicare enrollment, right? You may say, well, this is not going to work. I'd rather stick with my providers. And so I'm going to opt out of a DSNP, right? That is a possibility. And you can go ahead and do that. Now, I would say, we'll talk about this in the next slide a little bit more. We do have some kind of assurances in there to help ease that transition. But at some point in time, you will possibly need to switch providers if your new Medicaid plan doesn't have that same group of providers. You will also possibly be changing your care coordinator. That's going to kind of depend on what choices you're making, but just note, if you have a Medicaid care coordinator and a Medicare care coordinator, you're going to be moving, your Medicaid will be changing, and so your Medicaid care coordinator might change. And there's going to be possibly also a change in your supplemental benefits. You still get, say I'm an Aetna for both my DSNP and my Medicaid. You're still going to get the Aetna DSNP enhanced benefits, and you're going to get the Medicaid plan enhanced benefits. So you still kind of get two sets of enhanced benefits, but they're all going to be through one company now. And so because that is something that members try to focus on when they make a choice, we do want to point that out as well. So talking about kind of continuity of care, it is a part that kind of helps with the transition. So first up, if you're a nursing facility resident, this is not really going to impact you. Our continuity of care rules are such that if you're moving from one health plan to another for your Medicaid, and your new health plan doesn't have isn't enrolled with, doesn't have your facility enrolled in network, they cannot make you move, right? So they can't say, oh, you got to move to a different one. If you want to move, you can work with your new health plan on that, but you don't have to. So that person has to keep the health plan has to keep paying your existing nursing facility, even if it's kind of out of network. For pharmacy, it's a minimum of 30 days. So they have to kind of, you transition for refills, and so they have to make sure when you're transitioning that you have 30 days of refills, but it can be provided for up to a year. So, but they just can't, the MCOs just can't be oh, no more refills. Sorry, you got to submit a service authorization request or something like that. They have to kind of keep you, make sure your medication isn't going to run out. For all their provider types, there are kind of some different rules, but in general, for this group, kind of for duals, for the most part, you're going to get what's going to be kind of at least a minimum of 60 days with continuity of care. So that means the new plan is going to have to honor all of your existing service authorizations, all of your existing services, for at least a minimum of 60 days, but it could be for longer. And so if you have kind of standing medical appointments, should not be impacted. Your new health plan should not deny because you're like, well, I've scheduled an appointment on December 20th for an appointment on January 15th. You change plans, your new plan has to pay for that service, right? So just because it was kind of scheduled when you were with your old plan, your new plan still has to cover that. Question often comes up, well, how do they know? And actually, we send them that information. So we have a way where we get all of kind of your existing service authorizations and all of your existing services. We have those in our records here at DMAS. And then when you move plans, we send a report automatically. It'll go kind of over automatically. For those of you, we do get this question as well. For those of you who are getting like personal care services provided to an entity, so like you have to have, and this is going to be really kind of in the weeds, but let's say you have, let's say, an entity and they have a fiscal agent that's working with you, that we have a way for that fiscal agent to transfer from one health plan to the other as well. So this is again sort of like a similar kind of situation with the provider where maybe not all fiscal agents are enrolled with all health plans. That's right. Your new health plan still has to work with your existing fiscal agent. Yeah. So, and again, I'm almost done. We'll have some for some questions. And so I know this is probably going to be an area we get a lot of questions. I think this is the one where I think most members and caregivers are most worried about. So our outreach plan for this, just as an FYI, so activities that we've done in September, we've done a bunch of one-on-one meetings with kind of provider associations and other stakeholders to discuss this change. So similar to what we're doing here today, we've reached out to CSBs, nursing facility associations, home health providers, hospitals, and so we've worked with them as well. Oh, I'm sorry, I think a slide advance there. And then in October, so already what you all should, if you are unaligned, you may have already received a letter from your DSNP saying, hey, on January 1st, you're going to make the switch. They'll provide some information to you in there about like, if you don't want to make the switch, what can you do? You should be able to talk to your health plan about upcoming changes. We're also going to have some DMAS is going to send out some email blasts. And then in November, the Medicaid plan will also be able to start reaching out to unaligned enrollees. We want to sort of stage it that way. So the DSNP is going to do the first kind of outreach, then your Medicaid plan will do the second outreach and say, hey, you're unaligned, and so you're going to lose us on January 1. Now, if you are not unaligned, if you're already aligned, if you're not on the DSNP, you were just kind of here because you're kind of DSNP curious or just want to hear about Medicare, Medicaid integration, this doesn't impact you. It's only impacting those folks who are unaligned. And so if you don't get a letter, you shouldn't be impacted because the DSNPs and the Medicaid plans are only sending letters to those folks who are unaligned. And then in December, and right before your switch, you're going to get a new welcome packet for the Medicaid side. So that's going to have, kind of your new ID cards. It's going to inform you of your enrollment change. It'll give you kind of links or information like your benefits and your directories and that sort of stuff. So if you have questions, the first place that really we want you to kind of go to, or we would advise you to go to, would be to talk to your health plan. It's not that we don't want to talk to you. It's not that we can't assist you. It is just, the health plan is really will be the best place for you to go to get information about this change. Mostly that is because on the Medicaid side, we have an enrollment broker who can switch you on the Medicaid side. But if you're choosing a DSNP, only the DSNP can change you. We can't change your DSNP enrollment here at Medicaid. Only your DSNP can do that. So if you want to be making a different change for your Medicare, where you need to go is your Medicare plans. Right. But you can call, the Medicaid side or the DSNP side. They have, we provided training to them. They will be able to assist you as well. Here again, we have some some tools that for you to link to, some kind of resources that you may find helpful. If you are choosing a new Medicaid plan, there's a decision support tool. If any of you are familiar with like the star rating system on the Medicare side, this is very similar. It is a star rating system. It's much less developed, but it'll have a lot of the same information. And it's got a lot of the same basis of information like member satisfaction and health outcomes. We also have FAQs that we've linked to here. VirginiaManagedCare.com. This is the kind of the Medicaid managed care site. They have a comparison tool. This is also like if you're like, well, I want to switch my Medicaid plan now so I can be aligned come January 1. If you want to make that change now, you can call them and make that change. Also, Medicare Plan Finder. And then finally, the Virginia Insurance Counseling Assistance Program, or VICAP. Some of you may be familiar with them. VICAP this is a state-run program. Well, most of the VICAP counselors are volunteers. They provide free, unbiased, confidential assistance on helping people make choices, make enrollment choices. The kind of Medicare enrollment choices, or at least understand their Medicare enrollment choices. This next slide, and I'm not going to go through this in detail, but I wanted you to have it just in case. So this is really what calendar year 2025, like kind of the DSIP model chart, what we call it. And so for those of you who are looking up health plans in Medicare Plan Finder, you might kind of see like, oh, it's called Aetna, Dual, Complete, blah, blah. But then you'll also see this first column, you're going to have these numbers, right? And so I know this is very small on this slide. It will be easier when you get it in PDF form. Promise. But so you might see like, it's like, oh, it's the health plan number is H1610. That lets you know that that is this DSIP. So we wanted you to be able to have this as just sort of a resource to being able to look up enrollees. Now, I also want to point out on here, you will also see Humana on here. And if we go back to kind of earlier conversations, you know that I said, well, we have 5 health plans and didn't include Humana. So in that procurement, when we did our notice of intent to award, we had Humana coming in and Molina leaving. Oops, sorry, I don't know. For some reason, the slide deck wants to advance without me actually doing anything. So sorry about that. But so that's where we ended up with Humana coming in. However, because we have this protest that's in the court system, Humana is not starting yet. However, if this protest gets through the court system, and if the way that DMAS kind of proposed to procure it, which would be Humana coming in and Molina leaving, Humana will start, but they will start kind of mid-year. So if you're going out and looking at Plan Finder, you may see Humana right now, but there's going to be like a little asterisk, a little note there that will say is not accepting new enrollees at this point in time. You cannot enroll in Humana starting January 1, 2025, at least not yet. Until they get through until the procurement gets finished, Humana is just kind of they're there in name only, but they can't start practicing, but they may start practicing mid-year, mid-2025. And then that is it. Oops, sorry, wrong way. But I do also want to point out, if you do have questions outside of this, please hit up you can email DMAS at this website here. Rhonda and Natalie and myself all answer that. And so we can hopefully try to get answers to your questions there. And that's it. I know, sorry, it went a little bit longer than I expected, but hopefully we still have some time for some Q&A.
It was great information, so certainly worth taking the time. We'll get in a couple of questions here. So we had a good one about when a dual enrollee must submit their own claim for reimbursement, meaning maybe the provider accepts Medicare, but they don't do the billing themselves. Why is it that they've got to then submit it from Medicare and then submit it to Medicaid themselves, as opposed to Medicare receiving it when that person submits it and automatically passing it on to Medicaid?
That's a very good question. I don't know that I have an answer to the question. It's far enough strong.
That's a very
yeah. So generally how this works. So I guess the part where I'm not familiar about this would be like when a member is submitting a claim on their own. I do know that can happen. It's not something that I've run across a whole lot. So we might want to kind of
look
look into
with like
this.
Smaller providers, especially mental health providers. Maybe they don't have a billing staff, so they've done the work to be enrolled, but they don't have the work to follow up on the billing kind of thing.
Yeah. Yeah. So how it should work, how it works, just kind of if it's Medicare fee for service or in the future, how this will work with our decent program as well. It's like if you're submitting it to CMS, right? So they can pay it. CMS should pay it, and then that claim should be crossed over to DMAS automatically. Um, but I don't, maybe there's a difference when the person is billing on their own, right? Instead of the other way, instead of having the provider do it. I don't know what the intricacies of that are, but we can talk with CMS and try to find out like why that might happen or what a person is supposed to do in that
Okay, if
situation.
you have any information that you all learned, we're happy to pass it back out to folks who attended
Yeah.
today.
Yeah.
We did have someone with a question about the spend down, which of course is complicated, but I was going to say, do you suggest they contact their DFS or DSS worker or that they email that dual SNP email that you shared at the end?
Oh, either way, we can handle a number of kind of the spend down questions. I would say Rhonda, Natalie, and I are not like necessarily experts on spend down and how that works. But at DMAS, we have a unit who just does eligibility and enrollment, and they're much more familiar with the spend down. And so we can kind of take that and work with our eligible enrollment unit. And also our eligible enrollment unit works hand in hand with DSS on a daily basis. So really, I think either place would be fine to kind of understand your spend down. But sometimes this is not to badmouth any DSS workers, but I think sometimes we come across DSS workers who don't really understand spend down either. And so you may find it like if you're having trouble with DSS, feel free to reach out to us. We'll get you the answer.
That's great. We had a question here about, as people are navigating this, is the best route to call each provider to see, do they take each of these chosen plans? Is there a more efficient way to navigate that kind of thing?
So yes and no. So yes, in the sense that every health plan, whether you're talking about Medicaid or whether you're talking about Medicare, they have to post their list of enrolled providers. Also, if you're talking about Medicaid, you can go to, there was a slide a couple of slides back where it was, we talked about like the Virginia Medicaid Managed Care website. You can go there and electronically you can go and look for providers through that as well. So you can look by plan and look and see, like you can go and say, does Anthem have Dr. Barron's enrolled? And then you can go and look and search that. That's a good tool as well. And honestly, for the Medicaid side, that's probably the most up to date because the problem we have, and this is a problem, I mean, I have this problem with my insurance as well. MCOs are not always great at keeping their list of providers, their enrolled providers up to date. And you may also have a problem where like, yeah, I'm enrolled with Aetna, Anthem, United, whoever it is, as a provider, but maybe I'm not taking members right now because my member portfolio is all filled up, and so I'm not taking anybody. That may also not be on the website that you would be able to find. And so I would say kind of my advice would be start with the web page, start with, kind of the electronic one, either from the health plan, or if it's talking specifically Medicaid, you can go to the Medicaid managed care website and look there. But to be absolutely certain, probably easiest to call, right? So maybe you kind of narrow it down and say, okay, well, I have a choice of 3 or 4. Let me actually call these people and say, are you actually seeing new members, and that sort of information. So it's not great. This is an area that there's a lot of focus on from both the federal government and state government about how do we improve this. And so there's we just had a massive new federal regulation package come out that changes a lot of this. It's kind of forced the health plans to keep this information more up to date, but it's not a perfect solution. So it is hard.
No, it's a lot of work on families for sure.
It is, yeah.
We're hitting that, even giving ourselves a little bit of leeway time for technical difficulties and things in the beginning about that 1 hour mark. So I do want to go ahead and wrap up, but I wanted to remind folks we'll send you the recording and the copy of the slides. If you're watching this later and you registered, the slide should be in the email. If you're watching this later and you didn't register, just go to the arcofnova.org and click help to ask for those slides. And Matthew was so helpful about sharing that email address at the end is another great way to follow up. And as you heard, he and his team are the kinds of folks answering those questions. So you'll get actual real experts doing that. I wanted to thank you all and the ARC of Virginia so much for your time today and for all the work you put into this. This was tremendously helpful. And as you saw, such a big area of interest for our community.
Yeah. Thank you all. I just want to say, thank you. And please do feel free to reach out to us. Hopefully this has been beneficial to you, and yeah, happy to answer any other questions that we can. So thank you.
Thank you all so much. Have a great day. Bye-bye.
You